Hi guys, welcome back to sqadia.com. Nervus Trigeminus is the largest of the 12 cranial nerves and primarily responsible for the movement of the jaw muscles. So have you ever wondered how if these muscles don't work properly, you might not be able to chew or swallow? The loss of trigeminal nerve function is characterized by transient sensory disturbances in the territory of one or more branches of the trigeminal nerve. Facial sensory loss and oral sensory loss can occur individually or in combination and are caused by lesions affecting the trigeminal nerve or central connections, making the patient liable to self-injury. Well, how about we revise the names of the branches? The first branch, V1, is of the ophthalmic branch. The second branch, V2, is of the maxillary branch. And the third branch, V3, is of the mandibular branch. Now, from a mnemonic, we can remember how the skull foramina enables these nerves to pass through. S for superior orbital fissure, R for foramen rotundum, and O for foramen ovale. The expected or characteristic features of the trigeminal sensory loss may include the absence of the corneal reflex, that is the blinking of the eye upon touching it, absent sensation in the sensory distribution, or weakness and wasting of the muscles of mastication. How about we check out these muscles of mastication? There are four main muscles of mastication: the masseter, temporalis, medial pterygoid, and lateral pterygoid. Now, in trigeminal sensory loss, the patient might not be able to chew due to weakness of these muscles. These muscles are innervated by the mandibular division of the trigeminal nerve and can be tested by having the patient clench the jaw tightly or deviate the jaw from side to side against resistance. As we know, the trigeminal nerve has both sensory and motor function, but the major motor supply is carried by the mandibular branch, so it might not be affected as much. The mandible will deviate towards the paralyzed side when the mouth opens. Chronic unilateral lesions will present with unilateral temporalis atrophy. The good news is that most of the peripheral trigeminal nerve injuries undergo spontaneous regeneration. However, some injuries may be permanent with varying degrees of sensory impairment, ranging from mild numbness to complete anesthesia. So, for this reason, the fifth cranial nerve is routinely tested in the unconscious ICU patients as the sensory component of the corneal reflex. The corneal reflex is an excellent way to test the sensory component of the trigeminal nerve as well as the facial nerve. To test this reflex, the cornea is touched with a wisp of cotton and the resultant direct and consensual eye blink is noted. The afferent information for this reflex is carried by the ophthalmic division of the trigeminal nerve, and the efferent information is carried by the facial nerve. In the conscious patient, one may also test the sensation in the major territories, the forehead, the cheek, the chin, as well as the power of the temporalis and the masseter. So now we'll discuss the trigeminal sensory function. The sensory component of the trigeminal nerve relays sensory information from the face via three divisions, the ophthalmic, maxillary, and mandibular divisions. Testing of this component is accomplished by touching all three divisions of the face with cotton or a pin. In the unconscious or uncooperative patients, the presence of a bite block or Gudel's airway, also known as an oropharyngeal airway, jammed into the oral cavity alongside the endotracheal tube alerts the keen-eyed candidate of the possibility that the muscles of mastication are very much innervated and capable of forceful chewing actions. So this was a brief introduction of trigeminal sensory loss and why it's important in clinical practice. I'm sure you guys will be eager to know more about its detailed causation, so keep watching this video to learn more.